Welcome to Science Force, where science comes alive. Hello and a very warm welcome to this explainer. Today, we're diving straight into a topic that's deeply personal, widely experienced, but honestly far too often shrouded in silence. We're looking at the science and management of urinary incontinence. My goal today is to approach this sensitive subject with the utmost compassion, alongside absolute scientific clarity. So whether you're seeking to understand this for yourself, for a loved one, or for your own medical learning, you are in exactly the right place. Let's get started. Here is our roadmap for today. We'll be covering the basics of bladder control, 5 types of incontinence, the biology behind the leak, diagnosis and clinical red flags, treatment and management strategies. Right off the bat, look at this quote. A symptom, not a disease. Very common and often treatable. We really need to shatter the embarrassment and the immense stigma around the involuntary leakage of urine. It is so crucial to understand that absolutely anyone, children, young adults, new mothers, the elderly, can be affected by this. It's a biological reality, definitely not a personal failing. So, what is it exactly? To be precise, urinary incontinence is the involuntary leakage of urine, meaning a person just cannot completely control when urine exits the body. Fun fact for you, a healthy bladder can actually hold up to 2 cups of urine. That's roughly the size of a standard water bottle. But here's the absolute key takeaway. Incontinence is a systemic symptom. It happens because of a failure somewhere along the communication line, whether that's in the bladder itself, the urethra, the pelvic floor muscles, the nerve pathways, or even the brain. Section 1. The basics of bladder control. Our body actually possesses this beautifully structured assembly line. It starts up top with the kidneys producing urine. This fluid then travels down the ureters to safely rest in the urinary bladder, which is essentially a storage balloon. Finally, the urethra carries the urine out of the body. But it isn't just basic plumbing, it's a highly intelligent network. As the bladder fills up, nerves send urgent signals straight up to the brain. The brain then decides, okay, is the time and place socially appropriate? Until that exact moment, it commands the pelvic floor muscles and urethral sphincters to hold tight. But what happens when this delicate system actually fails? Well, the bladder might suddenly contract prematurely, or maybe it becomes vastly overfilled. Sometimes that critical nerve control is lost entirely, the structural supporting muscles weaken over time, or a physical obstruction literally blocks the pathway. And depending on that exact failure, a person might experience just a few uncontrollable drops, a moderate steady leakage, or a complete distressing loss of control. This is what drives symptoms like sudden urges, waking up constantly at night, and sometimes even bedwetting. Section 2. 5 types of incontinence. Let's walk through the different ways this actually presents. Stress incontinence. Think of a physical stressor. If you laugh, sneeze, or lift a heavy box and leak, that's because of weakened pelvic support. Urge incontinence. This is a sudden, intense neurological command telling you to go right now, often caused by nerve irritation or abnormal bladder contractions. Mixed incontinence. Exactly what it sounds like, a really challenging combo of both stress and urge. Overflow incontinence. This presents as constant dribbling because the bladder just can't empty properly, maybe due to an enlarged prostate. Functional incontinence is entirely environmental. The bladder works perfectly fine, but issues like severe arthritis or dementia physically prevent the person from reaching the toilet in time. It's also absolutely vital to recognize who's at most risk here. Due to the incredible physical events of pregnancy, childbirth, and the hormonal shifts of menopause, women face a significantly higher risk. But aging, obesity, chronic coughing, diabetes, and prostate enlargement in men are major risk factors too. And we really have to look at the complications with deep compassion. Left untreated, this isn't just about doing more laundry. It causes recurrent urinary tract infections, painful skin ulcers, and takes a severe psychological toll, leading to deep anxiety, depression, and terrible social isolation. Section 3. The biology behind the leak. Alright, zooming in for our life science students. At the cellular and anatomical level, continence is literally a masterclass in coordination. It relies heavily on a constant dialogue between the central and peripheral nervous systems. Now, the muscular wall of the bladder itself is called the detrusor muscle. Right below it sits this highly coordinated dual valve system, the internal and external urethral sphincters, and they are all resting securely in the hammock of the pelvic floor. Just look at the mechanical elegance of our autonomic nervous system in action here. During the storage phase, the sympathetic nervous system predominates. It's a state of calm holding. The detrusor muscle relaxes to accommodate the filling, while the sphincters tightly contract to prevent any leaks. Conversely, during the voiding phase, the parasympathetic nervous system takes over. The whole action flips. The detrusor muscle aggressively contracts to push the urine out, while the sphincters completely relax to open the gates. Any disruption in this elegant teeter-totter leads straight to incontinence. Section 4. Diagnosis and clinical red flags. From a clinical perspective, especially for the med students joining us, we need to break down the pathophysiology. For stress incontinence, we're typically looking at a urethral hypermobility or an intrinsic sphincter inefficiency. For urge incontinence, the main culprit is detrusor overactivity. Overflow incontinence, on the other hand, is generally a mechanical issue, so an outlet obstruction or profound detrusor underactivity. And functional incontinence, as we mentioned earlier, is driven by cognitive or physical impairment. Precision in identifying these exact underlying mechanisms is what guides effective therapy. So, what's actually in the physician's diagnostic toolkit? Well, it always starts with a meticulous medical history and physical exam, complemented by a simple urinalysis and a really helpful patient-maintained bladder diary. But for the more complex cases, we rely on measuring the post-void residual volume, or PVR, which is absolutely crucial for diagnosing overflow incontinence. We also use urodynamic studies to precisely test the actual bladder pressure, capacity, and muscle activity, and occasionally a cystoscopy for direct internal visualization. Red flag symptoms. Now, please pay close attention to this part. We absolutely must remain vigilant for severe red flags that dictate an immediate shift from chronic management to emergency evaluation. If a patient presents with visible blood in the urine, an unexplained fever, sudden new neurological weakness in the legs, severe sharp pelvic pain, a complete state of urinary retention where they literally cannot pass any urine, these are medical emergencies requiring immediate intervention, no waiting around. Section 5. Treatment and management strategies. Okay, let's talk solutions. Treatment always begins with empowering the patient through everyday lifestyle modifications. Just reducing body weight instantly relieves physical pressure on the bladder. Limiting caffeine is critical too because it acts as a direct chemical irritant to the bladder lining, while reducing alcohol decreases rapid urine production. Plus, stopping smoking physically reduces the sheer abdominal pressure caused by a chronic cough, and simply managing constipation can clear internal physical blockages that press right up against the bladder. Next, we turn to highly effective conservative physical therapies. The absolute cornerstone here is Kegel exercises. By actively strengthening the pelvic floor, Kegels provide vastly better muscular support and demonstrably reduce leakage for both men and women. Alongside this, structured bladder training gradually increases the time between restroom visits. This physically expands bladder capacity and actually trains the brain to calm down those sudden urges.
But what if lifestyle and physical therapies just aren't quite enough? Well, that's when we step up to medical management. Pharmacological solutions like anti-muscarinic drugs and beta-3 adrenergic agonists work brilliantly to chemically relax the bladder muscle and quiet down those unwanted detrusor contractions. And alongside medication, medical devices like pessaries for women can provide that necessary physical support, while specific catheters might be utilized carefully in select patients who are dealing with those overflow issues. Finally, when all conservative measures fail to restore a person's quality of life, we have an incredible suite of advanced surgical treatments. These include mid-urethral sling surgeries to physically support the urethra, the implantation of an artificial urinary sphincter, or simple bulking agent injections. For men dealing with obstruction, targeted prostate surgery can honestly be life-changing. And for really complex nerve issues, high-tech neuromodulation procedures can effectively rewire the bladder's communication with the brain. Conclusion. We've covered an immense amount of ground today, right? From basic plumbing all the way to advanced surgical interventions. But I want to leave you with a profound thought. With all of these highly effective treatments readily available, how can we better support one another in breaking the silence and the
Thank you for watching Science Force.